welcome to Smilow Shares with Primary Care. We're going to go ahead and get started here. My name is Ann Chang, and I'm here with Karen Brown and Kevin Billingsley, who have supported this series. This is year 2, so we're really excited to start and start our program. Let's see. Exactly. Here are our slides. Tonight, we're really focusing on liver masses and diagnosis and workup of liver cancer. We are going to, as some of you may know, this is a monthly lecture series that focuses on the primary care perspectives for cancer and hematology. Really, trying to look at the perspective and the questions of primary care. And we decided long ago, Karen, it feels like a long time ago, that we really wanted to highlight that relationship and to have a panel that had both primary care and Smilow physicians. And this will be going on monthly on the first Tuesdays, actually 5:30 to 6:30. So here are our featured panelists tonight, and I'm going to hand it off to you, Karen, to introduce our Dr. Zarcu-Power.
Sure. I have the pleasure of introducing my colleague, Flora Zarcu-Power, who did her medical training in Bucharest, Romania at the University of Medicine, Carol de Villa. Subsequently, her residency at New York Presbyterian Hospital in New York. And she began her practice as a hospitalist at the health system and also a clinical professor, assistant clinical professor, a teaching appointment for the first 4 years of her practice until she saw the light and realized that primary care is really where the action is. And she has been a primary care setting since then. She initially joined a large practice called PriMed, which is now part of Northeast Medical Group. She is very active within that at kind of how healthcare is organized and advocating for patients. This includes ACO membership, kind of board of ACO, an executive committee of the medical staff at first Milford and then Bridgeport Hospital, managing partner of PriMed, and a very active and helpful member of the primary care steering committee, as well as the care signature work here at the health system, where she's participated in multiple pathways. I think if they had an award for the person who's come forward for the most pathways from primary care, she would win it. She did complete an executive healthcare leadership program at the School of Medicine, and considers herself to be a very strong advocate for the relationships in medicine, the doctor-patient interpersonal connection being a cornerstone for great healthcare outcomes. I'll pass it to you, Ann, to introduce the Smilow team.
Thank you. Thank you. Dr. Billingsley is our Smilow Chief Medical Officer, and he's responsible for clinical cancer care across Yale Cancer Center and Smilow Cancer Hospital across the state. And he is also a surgeon, an international leader in clinical care and research of hepatobiliary cancers. And he maintains a surgical practice for care of patients with liver cancer, cholangiocarcinoma, gallbladder cancer, and pancreatic cancer. He's developed a particular focus in the treatment of patients with metastatic tumors to the liver, and his approach really involves extensive multidisciplinary coordination with medical oncologists, interventional radiologists, and other specialists. He has supported this series as CMO, and we actually asked him to be a participant this time. Thank you, Kevin. Dr. Ariel Jaffe is an assistant professor of medicine in the section of digestive diseases, and she's a board-certified internist and gastroenterologist with advanced training in transplant hepatology and in diagnosis and management of patients with liver cancer. She cares for patients as part of both the liver cancer program in New Haven and in Smilow, Waterford, as well as the liver transplant program, which also has a clinic in Stanford. She received her medical degree from Eastern Virginia Medical School and her residency training at New York Presbyterian Columbia before completing her training in gastroenterology transplant hepatology, and her postdoctoral research on HCC, or hepatocellular carcinoma, at Yale. So her current research is focused on streamlining clinical care and understanding the effects of various medical conditions on disease course and prognosis, and improving outcomes for patients with hepatocellular carcinoma. So thank you both, or thank you all for joining us, and we'll go ahead and move on to case one. We hope to have a few minutes at the end for questions. So if you have any, we've always had an engaged group. So put at the end, you can, or if we're, as we're going along, feel free to put your questions in the Q&A or the chat. Thank you. Flora?
I want to say thank you to Dr. Karen Brown for the generous introduction, for her leadership, and for taking the time to facilitate this series. A special thank you goes to Anne Chang, Dr. Chang, for organizing the series. And also, I'm very honored to have the incredible support of my colleagues at Smilow, Kevin, Ariel. Thanks to everyone for tuning in. I'll start discussing the first case. This is a 39-year-old woman with persistent elevation in alkaline phosphatase, but no symptoms of pain, no bloating, no nausea or early satiety. Denied weight loss, providers for jaundice. She had a right upper quadrant ultrasound that showed a large hepatic mass. Past history is positive for anxiety. By social history, she's married. She recently underwent IVF and had a successful pregnancy. Hoping for IVF in the near future. Consumes 1 to 2 glasses of wine per weekend. There's no history of illicit drugs, nor tobacco use. She's on no medications except long-standing use of estrogen-based oral contraceptives and rounds of IVF. In brief, her ultrasound showed a enlarged liver, measuring about 17.4 centimeters. An ill-defined area of posterior or hyperechogenicity was seen at the inferior aspect of the right lobe of the liver. And this is somewhat ill-defined and may represent a more heterogeneous treatment. A focal lesion cannot be entirely excluded, was the interpretation of the ultrasound. And the more prominent area measured about 2.4 by 1.6 by 3.4 centimeters. By color Doppler flow, imaging demonstrated normal directional portal vein flow. I'll turn it to Kevin, I think, further imaging.
So next slide, please.
I think you want to go back to the MRI?
Sure. So this is actually, before we go on, one of the things that we are often confronted with in the clinic as we see patients with liver lesions. A large lesion seen with a fairly unimpressive history, no history of significant underlying liver disease. And you can see that this individual has a large tumor that is enhancing on the contrast phase and is in a dependent portion of the liver. And of note, there's no morphology suggestive of cirrhosis. There's no apparently invasive element. There's no portal venous involvement, and there's no sign of metastatic disease. And like many cases, this is a situation in which the MRI is quite suggestive of a benign diagnosis, most likely a focal nodular hyperplasia, which is one of the many benign lesions which can arise in the liver and are quite innocuous, although they appear impressive on imaging. And I think that kind of opens up the discussion with the next slide of the variety of benign liver lesions that we encounter both in primary care as well as in our more specialized practices.
Yeah, so I think it's important to highlight it in primary care. I'm sure you guys come across a lot of patients that have what we call incidental omas. So I think just what I wanted to highlight in this slide is we've really increased across the board all forms of imaging. CTs, MRIs, ultrasounds have tripled and quadrupled over the last 20 years. And so I would say the majority of patients that we come across in clinic, these lesions are found not because they're symptomatic, but because they were scanned for other reasons, or a lot of times in young patients that have sort of vague abdominal pain. And I think a lot of what guides our approach is really distinguishing if these patients have underlying background liver disease or not, which makes us, more or less suspicious. Next slide. So, I wanted to highlight here, I think the first 3 points, the hemangiomas, adenomas, and focal nodular hyperplasia are probably the 3 most common benign solid liver lesions that we see. But we also wanted to highlight liver cysts, which are also extremely common, and then more rarely things like inflammatory pseudotumors and hepatic abscesses we have to think about on the differential as well. So hemangiomas are the most common benign liver tumor that we see. Incidence has been quoted in up to 20% of people just worldwide. They're more common in women, as we find really mostly all benign liver lesions are. And really, these are just benign vascular tumors. So histologically, if you look at them, they're just dilated vascular channels. Really, if someone has no underlying liver disease and it has like sort of typical findings on ultrasound and it's less than 3 centimeters, the guidelines will generally say that's actually enough to diagnose. But if there's a question of underlying liver disease, or we don't really know confidently, or they're larger than 3, then really all of these patients should get contrast enhanced triple phase imaging. So meaning with and without contrast, because we have to assess the contrast patterns in both the arterial and the venous phase. If they're sclerosed and there's some calcifications, it can challenge the diagnosis. But in general, even if these are 15 centimeter hemangiomas, if patients are asymptomatic, we really don't recommend any form of intervention. I will say that giant hemangiomas fall into a category of 5 centimeters or greater. And so in practice, usually if they're 5 centimeters or more, we will recommend at least a one-time follow-up within 6 to 12 months, just to make sure that there's no component of a hemangiosarcoma or any major change. And then hepatic adenomas are also, they're rarer than hemangiomas, also more common in women. These are basically benign monoclonal hepatocellular proliferations. The biggest difference between hepatic adenoma and the other lesions are that these do in fact have a potential malignant possibility. And so it's really important to make sure you tease this out, because these patients will require generally lifelong surveillance. The major risk factors, which we tried to highlight in the case that we presented, is that estrogens are very common risk factors for adenomas. So patients on estrogen-based oral contraceptives, obesity, because we know that that sort of central adiposity will actually make estrogen, glycogen storage disease, and then especially in men, anabolic steroids. So the typical pattern on imaging is it enhances on the arterial phase, and then later on it sort of has the same type of density to the background liver. We talked about the risk of malignancy, but there's also a risk of potential hemorrhage. And so for us, the big thing is the cutoff of 5 centimeters, and Kevin's going to talk about when we intervene or not. But that's a really big marker of when we get nervous and feel like we have to do something about these lesions.
So another very common benign liver lesion is something called focal nodular hyperplasia. And this is a fascinating entity because it is not really a neoplasm, but it looks like a neoplasm in the liver. This is a polyclonal proliferation of hepatocytes, which is essentially a reaction or almost an inflammatory response to localized increased blood flow from a small arteriovenous malformation in the liver, which is often congenital. So the risk factors are underlying vascular anomalies, although most patients who are diagnosed with FNH have no specific family history. The great news is that although many of these look quite ominous on imaging and can be quite attention-grabbing, they are 100% benign. The diagnostic feature, which is really pathognomonic, is a central scar on cross-sectional imaging. Obviously, a significant portion of these do not have a central scar, and they require much more nuanced interpretation of dynamic imaging, or in some cases, biopsy. The other piece of good news is that these are lesions that require no treatment unless they are symptomatic. Often patients and families do require a significant degree of reassurance because they see the images presented to them, often obtained for another reason, and they see this ginormous, to them, appearing abnormality in their liver, and it requires some real consultative support for people to understand that it is not a threatening process. Next slide, please. This is, oh, I'm sorry, back that up a little bit, Renee. So the photo on the left is a nice illustration of the central scar. And the photo on the right is a more subtle FNH on a CT scan. Next. So liver cysts are another thing that can be quite anxiety provoking, but in the main are entirely innocuous. I tell people that someplace between 30 and 40% of individuals will have at least a small liver cyst on imaging. I actually liken them in my conversations with patients to freckles in the liver because they are that common. The vast majority of them, fortunately, are simple cysts, and these can be quite large. They are anechoic unilocular fluid-filled structures, which are quite circumscribed and demarcated, non-enhancing, and there is no intervention that is necessary. Even a 5 to 6 centimeter cyst represents no threat of malignancy or rupture. Sometimes I'm asked by patients or families, what about the possibility of abdominal trauma, contact sports? And fortunately, we see no complications of simple cysts. Things do get more common or complicated in an entity called cystadenoma. These are cysts that are lined with a columnar epithelium, and they tend to have more thickened and irregular walls with echogenicity and nodularity. Sometimes there's mucin production. Cystadenomas require more aggressive treatment. Most of them are not malignant at the time of diagnosis, and most of them are asymptomatic, but there is a malignant potential over a lifetime. So patients with this radiographic appearance, a complex cyst, should be seen by hepatology or liver surgery for assessment. The good news from a surgical standpoint is that they can be resected very conservatively. And in some cases, we even don't resect the entire cyst, but just ablate some of the lining that in an area that can't be removed so that it scars down. Last and not least, unfortunately rare, are echinococcal cysts. This is an infectious etiology. The human beings are an intermediate host of Echinococcus granularis. These present with calcifications, daughter cysts. It's both a serologic as well as a radiographic diagnosis. And these are folks that should be seen by infectious disease and treated with albendazole, as well as liver surgery and hepatology. And the kind of multidisciplinary treatments probably a little beyond this discussion, but something to be aware of. Next. I do want to highlight the importance of really careful liver imaging and the evaluation of these patients. There are specialized hepatobiliary contrast agents, specifically Eovist or gadexetate, that is used in MRI. And the combination of appropriate imaging with contrast and, of course, a knowledgeable body imaging radiologist is really super helpful in assessing these patients. Benign lesions such as FNH demonstrate a very characteristic pattern, such as early arterial enhancement, persistent enhancement on delayed phase. And for FNH, the central scar does not enhance. Eovist for our cancer patients can also be very helpful in defining the extent of metastatic disease, but that's a little beyond our scope for today. So benign liver lesions, who needs to be seen by a surgeon and or a hepatologist? Often both. Let's start with adenoma. As Ariel indicated, adenomas are benign, but things 5 centimeters or greater or any min should be seen. Hemangiomas, anything that is symptomatic, mass effect or anxious patients. FNH, again, driven by symptomatology. And cysts, we talked about, the vast majority of them, fortunately, are benign. If they're large enough to cause symptoms, there are a variety of treatments we can deliver, including aspiration, which tends to be temporary, or a more definitive treatment of a cyst fenestration. And then we talked about the worrisome features for cyst adenoma that require more aggressive treatment, including thick wall, nodular, or mucinous fluid. Ariel, I think it's time to kick it back to you.
Sure. So this is a bit of a busy slide, but I just really wanted to highlight, for the primary audience that, when we get worried in our young patients that are of childbearing age who are considering pregnancy. So a lot of times these patients have indeterminate lesions. And the truth really is, without EVIST in general, it's actually very hard to distinguish FNH from adenoma. Hemangiomas tend to have a really different appearance with that sort of arterial filling that continues throughout the delayed phase. But the really important thing to note is that of these 3 most common lesions, the only one that really we worry about with estrogen exposure and particularly pregnancy is adenomas. So it's really important if you have someone with a liver lesion that can't be clearly defined, even maybe after EVIS, that these patients are really referred for discussion at a multidisciplinary tumor board. Sometimes biopsy is necessary. We know that there's a really significant morbidity if there's hemorrhage that occurs, and there can be rapid growth, especially later on in pregnancy when undergoing anesthesia is high risk. And again, we can't really use contrast agents once patients are pregnant. So if someone has a liver lesion, we really try to define. And if it's already nearing that 5 centimeter cutoff, we actually recommend surgery before going ahead with pregnancy, just given the risks. So I think that's the big takeaway, is that estrogen and pregnancy is a big concern in patients that have adenomas. And then Flora, you can present the second case.
We use the second case. This is a 63-year-old Asian female with a history of hypertension, diabetes, chronic hepatitis B virus, and on antiviral therapy. A right upper quadrant ultrasound done for hepatocellular carcinoma screening showed a new 4 centimeter liver lesion. So this person has been screened as expected, and all of a sudden has a new lesion. The MRI with and without contrast showed a 4.3 centimeter lesion with arterial enhancement, venous washout, and pseudocapsule. The LERADS 5. We'll hear more about it in a moment, about this categorization. Patient had a MELD 3.0 score of 7. And I'll turn it to Kevin.
Yeah, and this is an example of a person with underlying chronic liver disease, although they have well-preserved, excellent liver function, but with the history of hepatitis B, they are at risk for developing primary liver cancer. You can see in the picture on the upper left, this is why we underscore the importance of contrast in these images. There's brisk enhancement in the arterial phase, demonstrating this peripheral lesion in segment 7 and 8 on the back part of the liver. The panel on the right side is what's called washout, which means delayed images. The lesion kind of disappears as the contrast washes out. And then in the kind of equilibrium phase, there's something called a pseudocapsule, which is some contrast retained at the periphery. So this constellation of radiographic findings is virtually diagnostic for a small primary liver cancer in this patient with underlying liver disease. Next. So liver cancer is an enormous global healthcare challenge and is certainly something that we face here in Connecticut. The most common primary liver cancer is HCC, or hepatocellular cancer, accounting for roughly 90% of all primary liver cancers. Cholangiocarcinoma is also something we see arising from bile ducts inside the liver, as well as gallbladder cancer, which although it arises from the gallbladder, often extends into the liver and presents as a liver tumor and is often managed as such. And then more rare entities that are angiosarcoma or hemangiosarcoma.
So just kind of quickly, reviewing the statistics. So this is from the SEER database, and basically highlighting that there has been an immense increase in both the incidence, but also the mortality of liver cancer since the 1980s. So incidence has nearly tripled. And specifically in the United States, it's actually the fastest increasing cause of cancer-related death. Globally, it's the sixth most common cancer and the third most common cause of cancer-related death. So it's really a major burden, and it's only just behind pancreatic cancer in terms of its lethal nature, that the 5-year survival is only about 20%. This is highlighting that we're basically really bad at diagnosing liver cancer early. I think in part due to definitely a deficit in screening patients and trying to catch them early. And this is really just highlighting, of course, the earlier you catch the disease and can offer potentially curative therapies, of course, the better they do. So we really need to improve picking up these patients that are at risk and screening them and trying to catch this cancer early. When you're in your primary practice and you're seeing patients, I think that there's obviously some risk factors that are, again, obvious to us, but highlighting again the major causes of underlying liver disease and even independently risk factors for liver cancer. So we know chronic viral hepatitis, specifically B and C, alcohol, toxic or anabolic steroids in men can actually independently lead to liver cancer. And then I know it says NAFLD, I should have updated the new nomenclature, which is metabolic dysfunction associated steatotic liver disease. So MASLD, or what we think of as fatty liver. But it's also important to note that patients that have diabetes and obesity without underlying fibrosis are independently at risk for developing liver cancer. So I think that in primary care, this is going to be something that you guys see more and more, patients that had no clear evidence of underlying liver disease that present with large tumors. And it's really challenging our understanding of who to screen. And then, of course, the more rare causes like autoimmune, hemochromatosis, and things like that. So in terms of treatment, I highlight that the majority of these underlying risk factors do have treatments, right? So from a viral hepatitis perspective, hepatitis C is essentially something we can cure in really probably over 98% of patients if they actually take their medications. Hep B, we can suppress. We can't quite cure it, although there's a lot of research looking at that. I know we have really a growing community to help with addiction. And so for, alcohol use disorder and tobacco, there are medications and programs we can get people into. For metabolic syndrome, there's a variety of, right now really it's just weight loss and diet, but we're, prescribing more and more of these GLP-1 agonists, and we have a lot of clinical trials here. And then for patients that have more rare and, autoimmune or genetic disorders, we have therapies as well. So I think identifying these patients is important because we absolutely can, do better to treat these risk factors, and if there's really concern for advanced disease, to get them in care with hepatology early on. So in terms of screening guidance, so the AASLD, which is sort of our governing body that provides evidence-based guidance on the management of liver disease and probably what most hepatologists in the country use, just came out with updated guidance this year for liver cancer care. And kind of to summarize this, still really our cost-effective guidance only suggests screening patients that have known cirrhosis. But it's important to know that if you have a patient who's extremely decompensated, child C, very high MELD, you don't want to screen them for liver cancer if they're not a transplant candidate, because if you find it, you're not going to be able to treat them. So patients with somewhat well-preserved liver function and cirrhosis should undergo screening. And then the one caveat is patients with chronic hepatitis B. So we know that this is a virus that can lead to liver cancer without any underlying cirrhosis or advanced fibrosis. And you can see that there's sort of guidance as to age cutoffs in patients that are from endemic areas. And this is a pretty global, it includes a large number of countries. So all of Africa, all of Asia, various parts of the Caribbean, Eastern Europe. So, you know, it includes a lot of patients. And if there's a family history of HCC, and sometimes it's hard to always know. And so again, anyone with underlying chronic hepatitis B really should probably be seen by a hepatologist. I think this will change over time as we see more and more, but right now there's really insufficient evidence to support screening patients that have underlying fatty liver without cirrhosis. But what's really alarming is that studies are showing that up to a third of patients with metabolic associated liver cancer actually don't have any significant fibrosis. But because of the substantial number of patients in our population with this, it's still an overall low incidence. So there'd been a lot of back and forth on how we screen patients, and the guidance now really shows that combination of both ultrasound and AFP every 6 months should be the baseline screening. So AFP had been in and out. It's now added back and has shown increased sensitivity to pick up these patients. What's also challenging is that most of our patients are very obese or have super shrunken liver that's nodular. And so if the ultrasound read comes back saying limited exam, poor quality, can't rule out small masses, I would alternate really with a triple phase MR or CT every other time to make sure. And just anecdotally, it's pretty alarming how many lesions are not seen on ultrasound that are picked up. And then, you know, sometimes patients get nervous because their AFP comes back 11 or 12, and, you know, it shows that up arrow on their labs, and they're concerned. But really, a value more than 20 is what we consider significant or a global trend. So if someone started out at 3 and has continued to progress, that would make you more alarmed to consider getting, you know, cross-sectional imaging. And then I just wanted to highlight really, because again, I'm sure in primary care, we're seeing more and more patients with metabolic syndrome. And so again, these patients can present really subtly, very mild elevations in their liver enzymes, AST, ALT in like the 40 range. And then really when you check, they've had cirrhosis for probably a long time. So high risk patients, anyone with diabetes, anyone with medically complicated obesity. So, you know, so comorbid conditions like hypertension, hyperlipidemia, anyone that has a first degree relative that has fatty liver related cirrhosis because they're 12 times more likely to also have cirrhosis. Or if they have concomitant risk factors, like they drink excessively and they have metabolic disease, the guidance for primary care is that all of those patients should get a FIB-4 test. So it's a blood test, it's inexpensive. And if that comes back suggestive of possibly F2 or higher fibrosis, so some degree of fibrosis, these patients should then get really like an elastography is a good test. If it's a very high FIB-4 and you feel confident there's imaging findings, then those patients should be referred to a hepatologist. But it's important to know really diabetes with findings of fatty liver on ultrasound or abnormal liver tests, all of those patients need to be screened for advanced fibrosis. And that needs to be repeated every 1 to 2 years. Kevin, I'll let you jump in to describe LIRA.
Yeah, so thank you, Ariel. I think one of the things that we have touched on that I want to kind of peel back the onion a little further in is something called the LIRAD staging system. And this really highlights the fact that with specialized imaging, particularly CT or MR with contrast, done with the appropriate protocol and by an expert body imager, we can make really accurate diagnoses of small liver lesions in patients with underlying liver disease. This is the LIRAD staging system and it stands for Liver Imaging Reporting and Diagnostic System. And liver lesions are scaled from 1 to 5. 1 is definitely benign, 2 probably benign, 3 is of likely of indeterminate but concerning, 4 is high risk, and 5 is essentially diagnostic of malignancy. And you can tell that in the table, there are a number of features that work together to risk stratify these lesions. And they have to do with the size of the lesion, particularly if they're greater than 2 centimeters, the presence of arterial phase enhancement, as well as enhancing pseudocapsule and peripheral washout. So you start to add those pieces together, and when you have a lesion that's over 2 centimeters with arterial phase enhancement and either an enhancing capsule washout or threshold growth over serial images, that is diagnostic of a primary liver cancer. This allows us to treat many of these patients without a biopsy, or follow them with appropriately staged follow-up studies. Next. And I think this is for Dr. Zarcu-Power.
Thank you, Kevin. I'll jump in and I'll just make a brief introduction to the CARE signature pathway on liver mass. It is, we have to thank Ariel. She's the author, one of the authors, for developing this pathway, which is mostly for the inpatient, but could be 95% of it applied to the outpatient. So it serves very well for all of those who want to tap into it. It's available in Epic. You can just click on clinical pathways as you are in a patient's chart and sort of go down the path to decide what's the most appropriate next step you should undertake. Certainly, you could check it outside of Epic as well in our system and resources where you could review any clinical pathway. We'll go to the next slide and I'll just take you down the path a little bit. So if a patient with a mass did not have a sectional CT or MRI imaging using a triple phase liver protocol, then one should be ordered. Either an MRI of the abdomen, simply hepatoma protocol will suffice to click on this and eventually end up with that as a imaging we are ordering and signing off on it, or a CT of the abdomen, the same hepatoma protocol. If the patient has cirrhosis, chronic HBV infection, or past medical history of hepatocellular carcinoma, then AFP CA-199 have to be ordered. And certainly consultation with hepatology. And, if there are suspicious features on the imaging, and we'll move on to the next slide. By that, I mean growth, expansion, arterial enhancement, cystic lesion with solid components or associated biliary dilation or capsular retraction, one or more of these, then certainly this becomes again a referral to hepatology or to and to the Smilow liver clinic. So also one has to take into account if the patient has a known other primary malignancy. This is obviously a higher risk. And if the patient has a LIRADS of 5, which confirms liver mass being malignant, then it will be helpful to actually arrange a non-contrast CT of the chest to look for disease. You can move on.
So I'm going to jump back in here because as we work our way through these pathways, unfortunately, some of our patients will be diagnosed with primary liver cancer. And for people like Ariel, myself, transplant surgeons, medical oncologists, interventional radiologists, we all work together as a multidisciplinary team to drive treatment forward in a appropriate way for this group of individuals. And we really think, as we're assessing patients with liver cancer, of 3 broad categories of clinical information that all factor into decision making. The first is almost all of these patients have underlying liver disease. Many of them have overt cirrhosis. So we spend a fair bit of time trying to understand exactly how well their liver is functioning, because that determines their ability to tolerate surgery and other aggressive therapies. And we really use two clinical scoring systems to assess liver function. One is the MELD, Model of End-Stage Liver Disease, which is a bit more objective and relies on three biochemical assessments. Child Turcotte-Pugh or Child Pugh, sometimes just abbreviated as Child's classification, is a combination of laboratory evaluation, objective measurements, as well as clinical assessment of ascites and encephalopathy. They are both useful, and they're both used in a somewhat interchangeable yet complementary way. We also look at the tumor burden. This is the size of tumor in the liver, the number of tumors, and the presence or absence of portal venous invasion. And of course, many patients, unfortunately, will have disease outside of their liver, particularly in lungs, rarely in lymph nodes, but lungs are probably the most common metastatic site. And last but not least is patient functional status. What is their exercise tolerance, their performance status, and their overall burden of comorbid illness, such as cardiorespiratory or underlying renal disease. Next. So this is a daunting slide. I'm not going to try to go through it in detail, but it is to illustrate the almost overwhelming complexity of the decision-making in this group of patients. And you know, as you kind of walk through it, you can see that patients are allocated into a variety of treatment pathways, including ablation, resection, transplant, systemic treatments. And those decisions are all made on an integration of the three factors that I talked about. And those are all done within a multidisciplinary framework. Next. So I think, Ariel, you're going to talk about the workflow and the importance of the hepatologist as kind of the primary driver of multidisciplinary treatment for this group of people.
Yeah, so I think, you know, as Kevin highlighted, the vast majority of these patients will have underlying liver disease. And I really like to think of liver cancer as a cancer that develops in sort of a vital failing organ. And we're constantly balancing, you know, preserving liver function, which is absolutely the mainstay of being able to tolerate treatment and really what drives overall prognosis and survival in these patients. And so I think the reality is that when it comes to anyone that has underlying liver disease, they really should be in the care of a hepatologist. And, you know, really obviously as someone that works in the Smilow liver clinic, I think if there's a patient that's identified, in my opinion, as having a LIRADS really 3 or above that's going to need surveillance, they really should be referred to our clinic. And our role is to obviously continually assess what's the etiology of their liver disease, what can we do to recompensate these patients, what is the timing of their surveillance, because once you develop a spot in your liver, the modality of screening and the frequency changes very much. Generally, we're the ones that assess their underlying liver function and bring them towards the liver tumor board, which we have every week. It's a busy and well-attended tumor board with multiple disciplines that you can see highlighted here. And ultimately, they're treated, but this is not a one and done thing. Even in the best case treatments we can give outside of transplant, which include ablation and resection, 70% of these patients will recur at 5 years. So I really kind of describe to my patients that liver cancer is almost like whack-a-mole. Like you can hit one, but eventually, because you're not fixing the underlying issue, which is the liver disease, almost all of them will inevitably recur. And so they require lifelong surveillance, continued management of their underlying liver function, constant assessment if they're transplant candidates, you know, surveillance, understanding when it's appropriate to consider palliative options. And so it's a complex but really longitudinal care that we provide for these patients. Next. And then I'll jump back, maybe I'll review this slide and then hand off to Kevin to give some more details about surgery. But sort of broadly, we think about the treatment of liver cancer in two categories. So curative therapies, which include liver transplant. Not all patients will qualify, but liver transplant's actually probably the best long-term solution because, as I mentioned, it fixes not only the cancer, but also their underlying liver disease, liver resection, and then ablation, which we'll talk about a little bit later. And then we have our palliative therapies, which mean they're not supposed to be curative. They keep things at bay. They may end up, curing certain spots, but these are our transarterial therapies, which we'll also talk about a little bit later. And then our medical therapy, which is a pretty exciting new field.
So as Ariel mentioned, liver transplant is a unique and powerful treatment for this group of patients. And it is, in fact, the only therapy which not only rids the patient of the disease in its entirety, but also definitively treats the underlying liver disease. And for patients with truly end-stage liver disease, it is really the only viable option. And in fact, for carefully selected patients, the 5-year survival is 80% or greater, and really is the best possible outcome. The limitation has to do with limitations of organs, as well as the fact that patients with large or multifocal tumors are not candidates. Next. How do we make decisions about the therapeutic possibilities? This is my liver surgical oncologist simple-minded thinking about this. By and large, patients who have a primary liver tumor with no cirrhosis, if they have disease limited to the liver, many of them are good surgical candidates, and they need to be assessed very carefully for resection. Unfortunately, most patients have cirrhosis, and with rare exceptions, patients with cirrhosis, particularly if they have accompanying portal hypertension, are not good surgical candidates, and we have to explore a variety of other options. Some of them are transplant candidates, but there are a variety of other options. We talked about some of these things earlier, Child-Pugh and MELD score for liver function. We talked about, I mentioned portal hypertension as a accompanying factor with liver disease that is associated with poor outcome. We measure this with a hepatic vein gradient. A poor man's or poor person's equivalent of that is just assessing the platelet count. Patients who have a platelet count of less than 100,000 usually have clinically significant portal hypertension. And then we assess anatomic factors and the extent of resection involved. Next.
Wow, I must say thank you, Ariel and Kevin, for such compressed knowledge, superbly put together. I'll move on to the last case, which is a more complex case, and complexities obviously will lend to opportunities to discuss further treatment. So this is a 73-year-old patient with primary progressive multiple sclerosis, metabolic syndrome, NASH-related cirrhosis, who presented with liver lesion after undergoing HCC screening. His MELD score was 8. Which is low, it runs up to 40. He had no portal hypertension. Initial treatment was extended left hepatectomy in January 2022. Pathology revealed moderately differentiated with multiple satellite nodules and perineural invasion. Subsequently, this patient developed 10 months later a recurrence of 2.7 centimeter, which was treated with ablation. And then 5 months later, another recurrence, 2.7 centimeter lesion, which was again treated with ablation. And most recently, this patient has multifocal disease. And I'll turn it to Kevin to discuss further.
Yeah, thank you. So this gentleman, who is a patient that Ariel and I care for together, is really illustrative of both the excitement and the promise, yet the continued challenge of treating this disease. He is an obese man with non-alcoholic steatohepatitis or fatty liver disease. So his liver is not healthy, yet he does not have overt cirrhosis. And that was one of the things that allowed him to tolerate a major hepatectomy. You can see this was a large tumor arising in the left side of the liver. He had no signs of disease outside of the liver. He did have some comorbidities. We prepared him extensively for surgery, including cardiology assessment as well as physical therapy. He underwent a left hepatectomy, and you can see the surgical clips along the resection margin, and he was free of disease after that for about 8 or 9 months. It was 10 months. Then in the lower panel, as you can see, he developed isolated recurrence that could be treated with ablation, but then unfortunately developed multifocal disease and required systemic therapy. So this is a very oft-repeated scenario, but the good news is that we have more and more tools in our armamentarium to treat patients effectively at all stages of disease. Next. One of the things that it does merit a quick review is that even when patients are not resection candidates, they can be treated with these ablative modalities. One is radiofrequency ablation, which allows us to heat the tumor to destroy it. Microwave ablation is similar, using heat energy. Cryoablation we rarely use, but involves the use of freezing to destroy the tumor. And then a more recent technology is something called irreversible electroporation, or IRE, which essentially causes cells to lyse by breaking the cell membranes. Next.
So again, just briefly, because some of the notes you may read of these patients, I'm sure you see the words taste and tear. And I wanted to highlight that similar to the way we can take advantage of diagnosis and imaging, the majority of the background liver is supplied by the portal vein, whereas tumors actually get their blood supply from the hepatic artery, which is why they'll enhance on imaging compared to the background. And we can take advantage of this dual blood supply to very selectively deliver different forms of therapy through the vasculature. So TACE, we're delivering small embolic beads filled with chemotherapy. And so it not only causes a cytotoxic effect directly into the tumor, but it also actually plugs the blood supply, causing an ischemic effect. And TARE is the same thing. We deliver radiation beads to the liver, and it does not cause an ischemic effect. Those beads don't cause blockage of the blood vessel. So it's helpful if someone has a portal vein thrombus. Next. And then just really briefly, because I know we're running out of time and I want to have time for questions, it's really important to note that prior to 2017, we basically had one option for systemic therapy that was poorly tolerated and really only extended patient lives by about like 6 months or so. And since that time, there's been a really significant amount of research and successful research in the lines of systemic therapy. We now, along with many other cancers that I'm sure you guys have heard about, use immune therapy as our first line agents. And we're really seeing that patients are living on average close to up to 2 years after, and even up to 30% of those patients are having complete response from medical therapy, which is just absolutely remarkable, you know, compared to where we were, 7 years ago. And I won't go into detail about immune therapy, but our agents really block 2 different receptors that are expressed on immune cells, and basically prevents the tumors from evading the immune system and allows our own body to sort of attack the cancer. Next. And then, not surprising with that, when you sort of disinhibit or unleash the immune system, you can imagine that any organ can be involved. And so I think that you've probably had this talk from other providers, but again, any organ can be involved. I think anecdotally, the most common that I probably see are thyroid issues, as well as GI issues. And the treatments really depend on the severity of the toxicity. Anywhere from just holding the therapy to steroids to even more aggressive treatments like IVIG or more aggressive immune modulators. And so I think really just to summarize, we did our best. This is a really complicated disease that, again, more complicated because it often occurs concurrently with underlying chronic and advanced liver disease. And I can't explain, we have a really great group of providers. We really depend significantly on multidisciplinary discussions. There's a variety of treatments, and the big thing, I think there's going to be a lot of updates in the field. And, you know, I think when in doubt, refer to us for second opinions. But no doubt in primary care, with the growth of metabolic disease, you guys are going to be seeing more and more patients with liver disease and liver cancer. And I think there's one more slide.
Ariel and Kevin, impressive presentation. And I'll start out with the first question, if I may. What is the data, if we have, on survival with various treatments in the palliative group of patients? So those who we're not attempting cure. With the new reality of, you know, our U.S. healthcare system eventually moving on, possibly over the next decade, if not sooner, into value-based care models. Sometimes we are seeing in our offices patients who say, well, doctor, is this going to help me? Is this going to be too toxic? Is this going to impede on my quality of life? You know, I want to golf in the summer. I don't want to miss that out, you know? So if I have a year left or two, you know, I don't want to be going through eventually toxicities with systemic therapy and such. So do we have some of the data on survival in patients who are non-curative?
Yeah, so I think that in general, if someone is undergoing basically best supportive care, meaning no treatment at all, the truth is that a lot of times that's driven because their underlying liver function is really poor. So our data on that, if you look at actually the BCLC system, it'll put these people in like an average survival of 3 months. The truth is, if someone has preserved liver function, and decide not to get treated, they probably can live longer. But even our therapies, like the, you know, palliative therapies, transarterial, radiation, systemic, these patients are now living 2 to 5 years. And the truth is that I think part of our weekly discussions of if these patients are appropriate candidates really hedges on the risk benefit. So if someone has poor functional status, really poor liver function, where we think that we may cause more harm than good, as a group, we really probably won't recommend treatment. But I have to say, the majority of patients, when we evaluate them and feel that they can tolerate treatment, have pretty minimal side effects, and continue to live pretty normal lives after therapy. Even those on systemic. That's sort of the beauty of immune therapy, is you wouldn't even know these patients are getting, you know, medical treatment.
Thank you.
I want to jump in on that, because I think it is a critical question, not only from a value perspective, but just kind of, we all need to be listening to patients and delivering what they're asking for. And, you know, I think Ariel's touched really on the key points, but I would say it's remarkable how some of these patients can have a liver-directed treatment of a TACE or an ablation that is quite non-morbid. They're in and out of the hospital quickly. And a lot of what we're doing is with the hepatologist medically managing their liver disease so they do have the best quality of life. You know, and that's, you know, diuretics and beta blockers and, you know, careful visits and just all of that kind of, frankly, meticulous medical management that makes a big difference and keeps people out of the hospital from decompensations.
Well, my job was to monitor the questions submitted by the audience, and we have not had questions submitted by the audience, which I am sure still reflects very good attention. And we're also drawing near the end of our time. So I will go ahead and wrap us up with great thanks to each of the panelists for their time. I learned a lot. I'm still having a little chest pain about doing every 6 months ultrasounds and AFPs if we start to do this on everybody with metabolic disease, but I'm going to try to get over that and prevent as much diabetes as possible in my patients and manage it as well as possible so that we don't end up screening and finding more liver disease. So thank you very much and have a good evening, everyone.
Great to see you all.
Thank you.
Bye-bye.